I want to welcome all of you to the third Thursday. Again, I'm Wendy St. Peter from the College of Pharmacy. I am the chair of the Academic Health Center Faculty Consultative Committee this year. And I just wanted to let you know we are your representatives at the level of the Academic Health Center, as well as the faculty or the University Faculty Consultative Committee, and all the way up to the University Senate. So we want to make sure that you have representatives in the AHC FCC from every college within the AHC. So I see a few people here. I think Kathy Christbaum, where are you? Oh, she's sitting right there. School of Nursing, we've got Kathy Carlson from Vet Med. Paul Jardine couldn't be here from Dentistry. We've got Kiki Sarfafoglu from School of Medicine. We also have Angela Moratori from School of Medicine. And who am I missing? I introduced you. You weren't here. That's Kathy. And John Connett from the School of Public Health. So those are your representatives. We have an AHC FCC website that actually has a comment box on it if there's any issues or things that arrive, that you can either contact your representative or use that mechanism as well, okay? So these third Thursday events, for everybody that hasn't been here, is really a mechanism to get us together in a more casual atmosphere, to connect with one another on really important topics that are interesting in research or the education areas primarily. And so this is really to form networks and do it through a collegial way. So we're just appreciative of all of you being here. And I want to welcome our speaker for today. We have Dr. Harold Tu. He is from the School of Dentistry. He is an oral maxillofacial surgeon within the school. Perfect. Did I say that perfectly? Actually, I learned about him through an AHC newsletter that was talking about the opioid epidemic, and there was a really nice feature on the AHC newsletter that talked about dentists being the front line, one of the front line healthcare professions in this opioid epidemic. So it's clear there's a lot of interest across the AHC in Duluth and Rochester on this topic. I know I'm starting a research project in the opioid area, so this is our chance to get together. I think there's probably a lot of opportunities in this area, so those are some of the things that we want to stimulate a discussion on today. So Dr. Tu, I'm going to give the microphone over to you. You've got you're mic'd up. Right. So what we're going to do is have your presentation. What happens is afterwards, everybody can ask questions. I'm going to ask you to use the microphone so our colleagues in Duluth and in Rochester can hear us. So with that, I'm going to let you further your introduction. And I'm going to be your slide key.
Thank you for the invite. I'm a newbie to the Thursday conference, and Dr. Peter is going to volunteer to be an assistant in moving the slides. I've assured her that I will have this in the constraint of time that she's given me. So for the most part, this is a new audience for me. I've been giving these talks to my colleagues in oral surgery as well as general dentists, so you're kind of like a focus group. And so I welcome and look forward to questions and your response. So I am the chief of oral surgery in the School of Dentistry. Next. So I don't have any disclosures except the fact that one of ignorance and arrogance. Ignorance in the sense that when I began this process, I was ignorant of the magnitude of the opiate crisis, and arrogant, thinking that I, as an oral maxillofacial surgeon, knew best in terms of managing acute pain. And I would say that without question, I'm one of the larger prescribers of opiates in terms of as a practitioner. Next. So one of the questions you would have is, well, how does an oral surgeon in a 40-year career come to become an advocate? So it really started in October of 2015. I was at a rally, Fed Up rally, which is composed of people who have lost their loved ones to the opiate crisis. And during that walk around, I said to my wife, my goodness, these are pictures of my patients. And so there was a physician, Dr. Don Teeter, who is the director of the Safety Council, and in which his talk, he said, well, young people's first interaction with opiates were orthopedic injuries. And I also did ER medicine, and I said, no, it can't be. So I went to him afterwards, and I said, you know, Dr. Teeter, it's got to be dentist. And he goes, dentist? You guys prescribe opiates that much? And I says, yeah. So I started that journey of sort of self-discovery, self-study, and then end up in a journey of advocacy. Next. So this says it, I think, it summarizes the best. The unprecedented increase in opioid pain reliever consumption has led to the worst drug overdose epidemic in history. And I believe this is the largest healthcare crisis of our time. Next. So just to be sure, I state the obvious. I know that sounds, trite, but the fact is that oxycodone, hydrocodone is heroin. The chemical structure, as the pharmacist knows, is just basically the same. Oxycodone, hydrocodone is a little bit more lipophilic. It crosses a little bit brain barrier quickly. So basically, when we're talking about pain pills, we're essentially talking about heroin. Next. So to give a context of the state of the crisis, basically every day in the United States, about 90 people. These are numbers from the Trump's Commission on the Opioid Crisis. But about 142 people, individual Americans, die from overdose. And 2/3 of those are directly related to pain pills. Next. So if we don't bend the curve, what we're looking at is that we would anticipate that very quickly we will have 100,000 Americans die every year from this crisis. Think of that in context. This is startling. Next. So with the recent publicity about the tremendous tragedy affecting our families, loved ones, colleagues, and our community, this certainly has pushed, if you will, both our profession as well as legislatures to deal with this crisis. Next. So what and why did it happen? So that's curiosity, I think, has really led me sort of embarking on this journey of discovery, if you will. Next. So there's really 4 components that we're looking at: criminal economic behavior, patient expectations, the pharmaceutical industry, and doctor prescribing behavior. Now, there's been a great deal of emphasis on criminal economic behavior. In my thesis, and I'm going to propose that it is not the major cause. Okay? I mean, it's politically convenient for people to speak about those, but they're not crossing over the wall, so to speak. Next. So the United States contains 5% of the world's population, and yet we consume 80% of the world's opiates. Think about this, too. We consume 99% of the hydrocodone in the world. Okay? Next. So if we quickly look at what's happened in the United States, we just take a look at this map of emissions or opiate-related hospital emissions. So we'll quickly go through this. 1999. Next. 2001. Next. 2003. Next. 2005. Next. 7. And next. So every state in the United States has been affected, right? Obviously in different rates. But every state in the United States has been affected. No state has been left out of this picture of this rapidly expanding opioid crisis. Next. So this diagram is of interest because if you look at death rates, you look at heroin versus prescription drugs. You know, obviously you see the various differences in age, but I think if you look at it deeper, is a question you would ask, why is it that prescription opiates deaths is higher in older patients or older people and higher, if you will, for heroin in young people? Access? I think you're real close. But think about prescribers. Dr. Sick is here, and I think he'll validate this, which is the following. So if you kind of think about this, it's a little bit kind of intuitive. So doctors, physicians, and dentists are reluctant to prescribe opiates to young people, healthy, no comorbidities. We're kind of concerned that they're going to get hooked on opiates, right? Older people, especially white older people, they're more apt to get a prescription for any number of different complaints. I mean, we're just built that way, all right? I'm just as guilty, even though my demographics are a little different. So this is, if you will, a picture, sort of the dichotomy of our crisis, how it affects different age groups and different racial backgrounds. Next. Ann Cassie, who is a professor of economics, did really a fascinating study looking at the world. This is a remarkable change in mortality, and it's only the United States. Think about that. In all these other countries in the world, mortality, I'm sorry, I'm getting over cold, mortality is falling. Good thing. Responding to all the things that we providers in healthcare want. Medicine, intervention, et cetera, et cetera. But here it is, in the United States, a dramatic difference. Our mortality, for the very first time in developed countries, is on the rise. And it's a direct result of white people dying. Okay? Next. So this is the same study by Ann Cass, in which you can see in this graph the reasons why. Poisoning, this is related to opiates. Obviously, liver and suicides also has had a major impact as well. Thank you very much. Next. So what are the factors involving the epidemic? I see three major components. Dramatic increase in the opiate prescriptions, all right? Social accessibility of illicit drug use. And, in my opinion, the worst culprit is aggressive marketing by pharmaceutical companies, and what I hope to do is validate my claim. Next. Really what has changed in America has led to this crisis and the power and the influence of the pharmaceutical industry. You know, I don't know how many of you saw the 60-minute CBS? Yeah. It's really an indictment of that coupling of the pharmaceutical industry with our legislative body. I mean, it's, huh?
It was distributors.
Well, distributors, right. The end result was a distribution issue. Next. So what did the pharmaceutical industry really propose and change that caused this cultural change? They had two major points that they want to get across to us as providers and to patients, which was that non-cancer pain is an undertreated epidemic. All of us physicians here in hospitals, we got rated 1 to 10, smiley face, bad face, we got rated, okay? Joint Commission came in and said, hey, listen, you're not treating these patients correctly or appropriately. ER, so we were all guilty of being assessed and, in fact, indicted for that. Regulatory agencies, like in the state of Washington, basically turn things around and says, you know what? We're not going to regulate you if you overprescribe. In fact, it's the other way around. You can be criticized if you don't treat patients appropriately. I'm sorry. The second, opiates are effective to solve this epidemic, and the risks have been greatly exaggerated. I've got a whole continuous slides about how this came about. But really, if you look at the landmark article that basically said that opioid addiction was minimal, down to 1%, was a letter to the editor in the Journal of Medicine back in 1980. That was it. It's a commonly referred. Here's the interesting one: is in China they were using the same reference to promote the use of opiates. Okay. So, opiate prescriptions have tripled over the last 20 years, similar to death. If you kind of look at opiate prescription, bottom line is we prescribe enough opiates in this country for every American adult with an opiate prescription for a month. And here are some of the things I think you will need to take away from my talk today. 4 out of every 5 heroin users start with an opiate prescription. Okay? It's not the other way around. And over 50% of opiate prescriptions are from family and friends. So us doctors prescribing, most of the studies show that, like in dentistry, over 50% of our prescriptions are left over. Very similar to physicians. In fact, it's a little bit higher. This has caused a mass diversion, furthering the abuse of opiates. Next. So if you look at this diagram, it clearly shows the parallel increase of drug sales, opiate drug sales, deaths, and emissions. Okay? I kind of want you to focus on the dates. Okay? So this is just over from 1999 to 2010. So all of us are curious, well, when did this all start? Next. Okay, so if you look at hydrocodone, you can do this with hydrocodone, oxycodone, and so forth. So what happened in 1996? Did all of a sudden we Americans all of a sudden be with more pain symptoms, pain problems? What exactly has changed? Because prior to this, and I was a resident back there and trained right there, yeah, there was a reluctance to prescribe opiates. And I myself went through this process of thinking to myself, well, how is it and when did I start prescribing opiates at the level that I did? Was not based on science, and it was really based on, I think, really an indictment of ourselves because of perception and marketing. Okay? So you go, well, I don't know that. Prove it. Next. So I would say that this validates my conclusion. So OxyContin was developed by Purdue Pharma in 1996. It was an extended formulation of oxycodone. It really had little or no efficacy other than allowed, I apologize. So the formulation the patent was running out. So from 1996 to 2001, Purdue Pharma spent $200 million in marketing, sales, 1.5 million. A 700% great return on that investment, by the way. So we were extremely susceptible to this process. I won't go through all the things they did, but one of their primary goals was marketing to doctors. Currently, if you look at the pharmaceutical industry, besides being the largest lobby in the United States, they spend about $27 billion in marketing, $3 billion to public, and about $24 billion to doctors. Next. So if you look at total sales, it's an interesting industry. $10 billion in sales of opiates, about $7 billion of drugs to manage the morbidity of opiates. So they got us coming and going, so to speak. And I want you to put this in perspective, because I think sometimes when we look at numbers and what's going on. So I gave this similar lecture in Shanghai, China, my hometown, to the medical students at Tongji University. It was interesting because one of them raised their hand and says, why are you giving this lecture to us? Because we do not prescribe opiates. So I said, well, I looked at the following numbers. We have sales of $10 billion for a country of 1.3 billion compared to the United States of about 350 million. Your sales of opiates are 100 million. 10 billion, 100 million. And I said to them, I said, what I don't want to happen is that one of you would get up and give the same talk 30 years from now, because that's exactly what's happening in China. They're promoting the use of opiates, inappropriately so, especially for palliative care. But this is filtering down into non-cancer treatment. Next. So we as physicians and dentists need to accept our responsibility for being very much part of the opiate epidemic and take the obligation to be part of the solution. In my opinion, we have not reacted with the sense of crisis I think that we should. And I'll give you my sense. So all of us here remember the Ebola crisis, right? Well, not a single American died from the Ebola. I mean, people from an infection here in the United States. And yet all of us doctors, we knew the call, the clarion call from the hospital for everybody. We need to be committee meetings. We need capital expenditures, all and on and on and on. We haven't had the same sense of crisis when this crisis is basically exploding. Think about this. So death rates from 2015 to 2016 has increased a staggering 22% in 1 year. And this curve continues in spite of all the things that have been done that we thought were being done. Next. So let's talk about what's happening in our state. So this is in May of 2016. There was a Tribune article. What was interesting was dentistry was not mentioned. Next. Obviously increased awareness with Prince's death due to fentanyl. Next. So Minnesota, very similar tracking to what's happening in the United States. In fact, 2016, there's 402 death reported, and I just checked the Minnesota Department of Health, and we are currently in 2016 at 376, so we should be well on target to be above 402. Next. And similar to what happens in the rest of the country, more people die in Minnesota from prescription painkillers than any other opiates. Next. And again, our profile is very similar. Next. So who's dying? Male, white, 45 to 54, and most die at home. And as a result of the heroin epidemic, heroin mixed with fentanyl, they're not recovering. Yes, you're giving them Narcan, but they're found dead. Okay? Next. So if you kind of look at which counties, obviously Hennepin County is right there, right? I put the green one up there. Is 13 states in the United States have more opiate prescriptions than people. Shouldn't take great comfort in Minnesota because I checked. So right now we're on target to prescribe 3.5 million prescriptions of opiates for a population of about 5.5 million. So we're going to hit probably 4 million. Next. This is concerning for us in Minnesota because there's a 60% jump in opioid-related death from 2015 to 2016 in Hennepin County. But you know, really what's really scary is that in 2015 there was only 9 related to fentanyl, 39. And they're very concerned if carfentanil comes into the community, this will be disastrous because they're mixing heroin with fentanyl. Okay? So what are the solutions? I won't go through all of them, but bottom line is we got to prevent people from getting addicted, and we have to treat patients who are addicted appropriately. it's not sustainable to treat patients. This healthcare system there's just no capacity, and the cost to the public just will not be sustainable. So we have got to gear our major focus on preventing people from getting addicted, okay? So what do we do at the School of Dentistry, okay? And I've been involved in a number of set guidelines and so forth and so on. So basically compliment our faculty, our dean, who's here today, for supporting what I proposed was that we would have a mandated protocol, which is unique in dentistry because those who are not familiar with dentistry, we sort of practice really essentially in silos, unlike hospitals where you have protocols that are system-wide. We sort of do our own thing with sort of a collective understanding of common practice. So basically the protocol says that establish guidelines for safe and postoperative acute pain, and it's not intended to supplement and replace individual prescribers and clinical judgment. So, next. We started this in October of 16, next. And basically, NSAIDs would be the first drug of choice. If you vary from that, you'll have to document why, which is, you know, I'm sure, especially on the hospital side, is something that you're perfectly familiar with and accept. But I think it was really groundbreaking. I just returned from our own national surgical meeting. I believe that we are the first dental school, and I can't say for medical school, but the first dental school that I know that has a, if you will, a mandated protocol. Many schools are you know, especially, I think there's a consortium, Harvard, Boston, that they have guidelines. But, so next. So, quickly about outcomes. So, total prescriptions. Now, you'll be curious to say, well, geez, Dr. Tu, you started in October. What the heck happened? So what basically happened is that there is, in the School of Dentistry, a clinical affairs committee which has purview over clinical guidelines within the school. I presented this in February of 2016. It was accepted, and I implemented the steps in enrolling this throughout the various divisions in the school. And I think it began to have an impact almost immediately. As you can see, we're seeing a linear downturn in our prescription. So we average, now you go, well, how credible is this? We started abstracting data when we implemented our electronic health records. So it's pretty credible data. In fact, when we look back, we probably average about 4,000 opioid prescriptions a year. So overall, we just submitted our findings for publication. We've seen about a 48% drop in total prescriptions. And I think I failed to mention, so somebody said, well, you know, dentists, how much do they prescribe? So depending upon how you flesh out who's prescribing, we're probably second or third. We probably prescribe, well, we prescribe about 12% of all immediate release opiates, okay? But we are the largest prescribers of opiates to young people between the ages of 10 and 19. And that's seriously concerning because these are developing brains. We set them on a journey of addiction if we don't prescribe properly. Next. So if you break it down by the various divisions, oral surgery, obviously, we are the largest prescribers, perio and so forth. So overall, we've had the largest impact. Okay, but we did a rolling implementation. What I've done is I give this talk, implement electronic health records, implement ERX, and so we also, so one of the things that we can certainly talk about is PDMP, which is a database that you query for opiate prescriptions, and we have ERX. We've looked at our database and their database, and it's very similar. So we're pretty confident that we're not missing anybody. But the thing is, are we capturing such thing as a VA, nursing homes? And so we're still trying to figure that piece out. But for the most part, I think it's capturing almost all the same information. So overall, there's a downward trend in all the various clinic divisions. Next. We also have seen a drop in the number of pills prescribed per prescription. I won't show I dropped the slide, but we also have seen, with the drop in prescriptions, we also seen an increased number of prescriptions for NSAIDs. Next. The other thing that we've done unique is that we're doing a longitudinal study in surveying students, predoctoral students, residents, and faculty, and looking at trying to assess their prescriber behavior and their opioid knowledge. So it's going to be a very interesting. My hope is that obviously my goal is that it will make an impact on the prescriber behavior of our next generation of practicing dentists. And I'm pleased to say that we are making an impact in the community as well. In my partnership with Dr. Angie Rake, we've been going out and talking to our colleagues in general dentists, and over the last year and a half, we have seen actually a change in the response. I believe that we are, with I think audience such as this, that we are coming to a tipping point in which I think this is a particularly accelerated in dentistry. So if you look at the two professions that have seen the largest decrease in opiates is ER medicine and dentistry. ER is about 9 and we're about 6. In point of fact, it's interesting to note, someone say, well, geez, I heard, either read, that there's been a decrease in prescriptions overall here in Minnesota. The answer is yes. I think it's about 12%. But what should be concerning to all of us is, with that decrease, why is this crisis continue to skyrocket? Okay, so next. So I just kind of want to show you and I won't show you all the survey, but we're having a variety of different questions and surveys, and my hope is to see on a longitudinal basis of any changes. Interesting enough, though, to say that faculty are more knowledgeable than resident students would not be accurate. And that would go for me prior to this, because I've really been operating for my entire career on a lack of science, if you will, but more on perception. Okay, thank you. Any questions? Dr. Peters, you did an excellent job, by the way.
So questions. We've got some right off the bat here.
Yes, can you hear me? Doesn't sound like I'm on.
It is on, though.
It's on, okay. We also look at why do we prescribe, maybe because of patient satisfaction. So what kind of patient satisfaction are we getting from the lack of opioids? And have you tried, besides medication, any other comfort measures, heat, cold, other things that could take away pain, even in acute pain?
It's an excellent question. So really the question is really twofold, which is, are we seeing more pain management failures, right? Patients' complaints, patients, So what we've seen is, one, I'll just mention, of unintended consequences. The School of Dentistry, unfortunately, was, if you will, known as a place to get your opiates. Dentist. That's an often common access point. Well, as soon as that stopped and the word is out, they weren't getting opiates, they actually went to the emergency room. Now, I got a call from the ER docs and said, hey, listen, they're coming here after 5 because you're not getting opiates. I go, well, let me get this straight. We're like the specialists in dental alveolar issues. We just told the patient that they shouldn't have opiates, and you're giving them opiates. There's a disconnect here. So you need to refer them to the dentist or refer them back. So, the initial response, there was pushback from a certain group of patients. The only way we can track this is the following. So our protocol says the following. if they call back and says, geez, we're having more pain, we have them come back to be seen. As in my private office as well, I see my patients post-op and try to identify what the cause of that. So that is part of our protocol. The other thing is that we're tracking is the number of after-hours calls, and we have not seen that. So anecdotally, and to some degree, it's really observational, but anecdotally, we've not seen a significant increase in pain management failures. And I would say that that would be relatively school-wide, to somewhat of a surprise to us as well. And we are tracking that as we speak. I'm having the residents log all patient inquiries after hours and to kind of get an assessment of that. I would say that that experience from the private community, Dr. Angie Rake, actually, again, she has not seen a rise in that as well. The other piece is what ancillary adjunctive measures are we doing? Well, so for us surgeons, for example, preemptive medication, the use of nonsteroidals prior to surgery, either Toradol, IV when we're doing general anesthetic, or ibuprofen prior to doing a procedure. Things like heat, cold also are a very integral part of our patient discussion to minimize discomfort and swelling, etc. So I think without question, I think what I urge my colleagues and residents well is patient discussion. You want a great deal of one's pain experience is the anxiety of not knowing or not appreciating what your post-operative course is going to look like. So for someone like myself who does major surgery, I spend a great deal of time in discussing with patients about what to expect. One, you're swelling maybe much larger than the other side, and your pain is worse for the first 24 to 48 hours, but your discomfort is going to be managed, and you should be functioning, probably normally in 3 to 4 days. Things like that that the patient can hang their hat on. Yeah.
Thank you.
Here, can I bring in a Duluth comment? We have a question from Heather Blue, Dr. Heather Blue from Duluth. She says, thank you, Dr. Tu. What advice can you give to help us work interprofessionally with our students regarding the opioid epidemic? He's got it.
So I think the thing is, and I have a confession, is that I've been really speaking, if you will, to my own colleagues and to dentists and audience such as this, sort of interaction and awareness of what we do in dentistry and my knowledge about what others are involved in. I think that's where the interdisciplinary interaction starts, and hopefully build that sort of collegial interaction to find solutions, innovative solutions. I'll be perfectly honest with you, I don't propose this as a model or a template, but this is one approach, and certainly it is a work in progress. And I would be the first one to say to you, does it work in other sectors? I believe that that there needs to be many more such templates, so to speak, because collectively is where I think we will bend the curve. But I do think the central message from the way I see it is there needs to be a collective response that rises to the level where I feel the crisis is, because it is now, it is here, and it's not going away.
One of the ways for that collective, I'm Sheila Riggs from the dental school, but one of the collective ways I think we could learn from is the prescription monitoring program, the PMP. And, that's been available for several years now, and you call in to see if the patient has had another prescription. I mean, that's really what you get from it. 2 years ago, I spoke with the folks at the Department of Health to see if we could look at the back end of that database. Because on the front end, we can know if the patient has had a prescription, but on the back end, it's really a perfect all-payer database for all prescriptions in the state of Minnesota. And Jeff Schiff at that time, who's still at the Department of Health, said the way the law was written, the Minnesota Medical Association put into the law that, okay, we'll go along with the PMP, but no one can ever do an analysis on the back end of the data. There cannot be physician or prescriber profiling from the back end of the PMP. And I think as we go forward on this, it is at such a crisis stage that we need to collectively go to the legislature and say, we had to bring sense to that law and let some researchers really understand who are the major prescribers, who you need to go speak with to change their practices. Because if you're speaking to people who really don't prescribe all that much, that's great. They need to know. But we can know who is dumping this into our communities in Minnesota.
Well, let me be more direct, which is I think that's a hill that is too high to climb, especially with the opposition of organized medicine and dentistry. However, it is, I think, feasible, as 16 states have done, is to require mandated query of the PDMP. In fact, that in itself has had a dramatic impact in all those states. In fact, there was a study done in New York and in Eastman Dental Institute, in which New York is one of those mandated queries at PDMP. And I think one of the things you should know, some people go, well, in fact, when I gave the talk, he says, well, this is intrusive, government overregulation, it's a pain in the ass, you know, it takes time away from our patients and so forth. Not true. The way the PDMP is written, you can identify someone in your office to query the PDMP and come to tell you. So it's no big deal, just like we do, you know, in our practice as a routine part of, you know, medical records. And so you go say, well, has it made an impact? The answer is yes, dramatically so. In the Eastman Dental Institute, it dropped by 78%. And you go, well, why? I mean, what happened that this would all of a sudden dramatically impact prescribing behavior? They really couldn't find the right answer to, and the answer it's thought that just because people thought that someone else was looking over their shoulder about their prescribing behavior, that changed. Obviously, the initial impact. But here's the thing about the PDMP, because, you know, physicians talk about it. You know, in fact, the laws change here in Minnesota that all prescribers have to register. Sounds great. But if you look at those states, participation is like 7, 6, 8%. Yeah, just people don't participate, so it's really sort of a bogus thing, right? Our neighbors, Wisconsin, mandated queries of PDMP. And I talked to them, I gave a talk at UCLAR. I said, was it a pain? And then, you know what? The answer was no. So that would be one of the first things that could be done legislatively. I do think that there's support for that. I think that would be the avenue to go, not to diminish the fact that, yes, the other transparency. I think there are some other legislative things. I think it's called the Opiate Steward Bill, which is basically a 1 cent tax on every milligram morphine equivalents that's sold. This is to the wholesalers. That money then be identified and used for addiction. So there are things that we can do legislatively, and those are things, for example, I believe that Fairview Hospital, Fairview System, should take a leadership role. Right now, I'm part of that committee, and we are still working on guidelines. We need to be beyond guidelines. I mean, I'm on the ICSI task force, still working on guidelines. I'm not diminishing all that, but this sort of constant, I mean, the opioid workforce here in Minnesota, that was put out in 2015. I reviewed that and sort of used that, but as a template. At some point, we need to, as healthcare professionals, we need to move in a much more pragmatic approach. Any other questions? Yeah.
Yeah, this is, I'm going to try and put two questions into one, but when I've gone to the dentist and had oral surgery and was sent home with a big bottle of pills, I thought, you know, boy, this is going to be terrible. And then it turned out it wasn't, and I ended up having all these pills left over. Now, I feel like I'm a responsible person. I don't go advertise that I have them, but nevertheless, I know of people who are part of the sharing economy, and you know they pass them around, and so it's almost like a secondary black market that must be contributing to many of the numbers. And so, what I'm wondering is why can't we lessen the flow of the spigot coming out? You know, something on the model of you know, having monitoring be just part of the treatment. So, for example, if someone goes to the dentist or to surgery, then they just have to come back after 2 or 3 days for a reassessment, and then so that it's not just you give them 2 weeks worth of medications.
Well, as a practitioner, I would say that that approach, I think, sounds reasonable, very challenging and difficult. Because, you know, as I said in my approaches, that individual prescribing ability is something we doctors hold sacrosanct. And so, but you did raise a very interesting point, though, which is about your perception of pain and what you experienced and what was given. So a couple things. Almost universally, all the pain study models are done in a dental model. They're molar surgery. I don't know. Most physicians have no idea. I tell them, well, this is the model accepted by the FDA. So so I'll only speak to dentistry, but medicine, I think, is the same. Because if you ask orthopedic surgeons, well, why do you prescribe 50 Vicodin? Well, we've always prescribed 50 Vicodin. So, but I'll talk about dentistry. So there was a NIH study done on the Pearl Network, practitioners involved in applied research and learning. So it was 27 dentists, over 3,000 patients, and this was assessment of the post-operative response to pain medication. Okay, so they were numb. The dentist then sort of based on what they thought they were going to, the type of pain they were going to experience, they prescribed over-the-counter non-steroidals, prescriptions, and opiates. I won't go through all the numbers, but the bottom line was the following. Their conclusion was, one, no difference between non-steroidals over-the-counter, non-steroidals prescribed, or opiates. And, interesting enough, is that the perception of pain by both the patient and by the doctors were way overstated. In fact, a significant number of patients were like yourself. You said, oh gosh, I don't know, it didn't seem like that much pain. I don't have to take the Vicodin. So we have to change our prescriber behavior. I think that is the first and foremost. My brother-in-law just called me a month ago. I had a tooth out. Yeah. They gave me 30 Vicodin. Okay. I go, should I take them? I said, well, are you having any pain? He said, well, not really. He says, but they said to take them all just in case they didn't want me to be in pain. Now, that's kind of crazy on one hand, but it's perfectly, reasonable on the other, because he sees it as preventive. He says, basically, the doctor says, you're going to have a lot of pain, and I don't want you to be in pain. So the other thing is that here's an urban myth, and doctors accept it and dentists accept it. Well, if I give an opioid prescription, they'll be fine. I mean, they'll stop taking it after pain, and they shouldn't really experience any, addiction issues or misuse of it. Just to let you know. So there was an Arkansas study of about 1.3 million patients they've tracked, which basically you look at less than 3 days, 10 days, 30 days, and so forth. Bottom line is, starting about 10 days, you'll have these are patients with no previous opiate issues and so forth. you have 1 in 5 chance that you'll be misusing, or abusing opiates a year from now. More frightening, if you will, so there was a large pediatric study of about 6,000 high school students from age 18, okay, starting at 18, with no or naive opiates use, okay, followed to age 23, okay. 33% of them exposed to opiates will be using opiates, okay. Not addiction. There's a difference between abuse and misuse and addiction. I think that needs to be understood. So, yeah. Anything else?
Just a final question, I guess, going back to more on a broad view of what you presented, which was really, really very well presented. It's a clear picture of what's going on. Being so clear and being so evident what the problem is, and prescribing such a big part of the picture, with your experience showing that prescribing less is possible and you can go down with that curve, what are really the dragons, as you showed in, showing what are the causes that led to this crisis? What are the dragons now that are avoiding just the lack of reducing the prescription and assuming these protocols or these new ways of doing things that are avoiding this being just, a fact and just having this happening? I mean, just having new protocols and new prescription routines happening. I'm having a hard time understanding, why are we not just doing what you're doing with the dentist? Why is not everybody doing this?
Well, first of all, I don't want to be that arrogant that we should be doing what I'm doing. But having said that, the challenge.
Well, sorry if I interrupt, but
Yeah.
in Europe, that's what they're doing.
Exactly.
I'm coming from Europe, and my experience after a big surgery is that the maximum that I can get is a Toradol, but not, just if you really, really are screaming.
I appreciate the fact that you just made that observation, because this is a uniquely American issue, uniquely. And, it's going to require just discussions such as this, leaders in our hospital, medical staff, to affect change. I do believe that, so people have said, well, are you optimistic? So the answer is yes. And so I'm going to give you an example where awareness can make an impact. And this is kind of what you're talking about. So if you thought about the last public health issue that was really impacted, I believe, and significantly so, on awareness, public awareness, was MAD, Mothers Against Driving. I mean, if you look at the mothers about drunk driving, it went like this. That acronym really is like, hey, this makes sense. In fact, I'll just share this with you. So I've put together an acronym called STOP, Safe Treatment of Pain. And my proposal is a number of things, and I've been sort of sending this out, proposing that this acronym be something that we would adopt and move forward with. But I do believe that the tipping point can occur with public awareness. And I believe that as a result of that public awareness, that will hopefully cause prescribers such as myself to make those changes. And I'm becoming more optimistic as each time I've given this talk, to be perfectly candid. So, yes.
Last question. So part of the problem that took it up is incentives to get patients happy and, get the SMILE score up. So how is that changing now with accreditation incentives? Or are they looking at it in a reverse way?
I was maybe Dr. Sick can answer this, but I was chairman of quality assurance at University Hospital. I can tell you on firsthand in Nebraska that was one of the foremost standards that we had to deal with. Now, my understanding is that emphasis has significantly diminished, and I do not believe that is a current standard that the Joint Commission, and I think the regulatory agencies are also rethinking about. So I think the combination of that is going to make a difference. You know, I think healthcare entities will have to score less on that issue with patient response. Yeah. Did you have a question? Oh, okay. Yeah, I apologize. So thank you very much for